A 17-year-old woman now, a different story totally, is admitted to the hospital with right lower lobe pneumonia. She has history of prior pneumonias and multiple admissions to the hospital. She also has a chronic daily productive cough as well as chronic diarrhea. And let me tell you a little bit more about this because this is important here. The chronic daily productive cough, she says it's very productive. It's foul smelling, it's greenish looking, and then you say, well, how much is this? And then she says, she points to, a cup of glass. She says, yeah, I fill that, every day plus, another half glass. So very productive cough, foul smelling, greenish cough, not the typical one that you get with chronic bronchitis. People with chronic bronchitis have productive cough, but they don't produce, it's not so productive that they could measure it like these patients do. It's not foul smelling like these patients. And then, along with that, she has chronic diarrhea. So this is important because, where's the chronic diarrhea coming from? She seems to have something in her lung, but why is she having chronic diarrhea? You examine the patient, she's thin, she's in respiratory distress, her lung exam shows diminished breath sounds on the right lower lobe, and what she has is this disease called bronchiectasis. Now, if you compare bronchiectasis to emphysema, it's kind of like the same process. Patients with bronchiectasis have permanent dilatation of the bronchi, but it's above. It involves the small and medium-sized bronchi. So if you think about it, emphysema involves the terminal bronchioles to the alveolar membrane. So bronchiectasis involves the small and medium-sized bronchi. And there's two types. There's one that is diffuse because there's a systemic factor involving these cases, and the other one that's local because they've had an old pneumonia that's involved this area. And I'll explain that a little bit more. The systemic processes that cause bronchiectasis, think about the lung fighting off infections. It has a couple mechanisms to do that. It has immunoglobulins, it has the cilia, right? The cilia move, and you get rid of microbes and stuff like that. And then you have the cough. Those are the three basic mechanisms that the lung has to basically fight off microorganisms and infections in the lung and so forth. So if a patient has a problem with one of these three mechanisms, then the whole lungs get increased infections. And what does that? What would be systemic factors that would do that? Things like cystic fibrosis, where these patients produce these very thick cough that kind of block their bronchi, right? So they can't get rid of microorganisms with their cough, cough process, or people with cilia dysmotility syndrome, where the cilia is not working well. And some of these patients, not all of them, have dextrocardia, and this is called Cartaginer syndrome. But basically, the cilia dysmotility is what affects the lung. And then the third one, people that have immune globulin deficiency, like IgG deficiency. So think about systemic disease that would cause the lung to lose its fighting apparatus against infections. Cystic fibrosis, cilia dysmotility, immune globulin deficiency. And then we talked about a more localized process where I said they've had some kind of pneumonia there. So maybe the person as a small child had a pneumonia there. It involved some part of a devastating pneumonia like staphylococcal pneumonia, tuberculosis pneumonia, and what it does is it destroys the bronchi because of the infection. The staphylococcus pneumonia is the typical one. It destroys the bronchi, and now these bronchi are dilated, permanently dilated. They get infected. And as they get more infections there, because they're permanently dilated, so they're not functioning, so they get more infections there, and now more infections bring more bronchiectasis, and more bronchiectasis brings more infection. So this is like a vicious cycle. So localized versus systemic bronchiectasis. The presentation is the same in both cases, where these patients produce purulent, copious sputum, lots of purulent, copious sputum. The patient usually quantitates, they tell you, a glass or two a day. And they have recurrent pneumonias, and then the problem is that these pneumonias, especially as the disease progresses, they tend to develop gram-negative pneumonias, especially Pseudomonas. So that's devastating, because usually when somebody comes into the hospital, you don't suspect a gram-negative pneumonia. Most of the patients that come in come with gram-positive pneumonia, strep pneumo, and stuff like that. It's only these patients that get the gram-negative pneumonias, and you have to suspect it because of the history that this patient had before. And then the last thing that sometimes happens is they may get massive hemoptysis. The bronchi seem to erode into a vessel, and then these patients get massive hemoptysis. How do we diagnose? We get a chest x-ray, and sometimes they tell us about the crowding of the bronchi on the chest x-ray and the tram tract signs. These are all like dilated bronchi, and that's the first evidence of bronchiectasis, the chest x-ray. And then we do a high-resolution CAT scan, which is the best non-invasive test to diagnose this. And here's a picture right here, and you can see, look at this here. Compare this side, right, to this here where you don't see any bronchi. Look at these bronchi here, they're permanently dilated. This patient here had a form of localized bronchiectasis. Now that's important. That's important. So after we diagnose bronchiectasis, our next thing here is to find out, is it systemic or localized? So we start looking for cystic fibrosis. We do a chloride test, right? We start to look for cilia dysmotility syndrome. And then we start to look for immune globulin deficiency and so forth. We want to exclude systemic disease. In systemic disease, you've got to treat the systemic disease to prevent bronchiectasis. In localized disease, one option, and we're going to be talking about treatment, is to come in and take this out surgically and kind of prevent the vicious cycle. So the treatment of one versus the other makes a big difference. So after we document bronchiectasis, our next plan is to find out which of the two types we have, the systemic or, right, the localized. After we do all this, then we decide to treat the patient. And in the chronic, in the outpatient setting, bronchodilators are very efficient, because this kind of acts like an obstructive disease. We do chest physical therapy, where they do chest compressions and stuff like that, and postural drainage. And then, because these patients then tend to get infections throughout the winter months and throughout the year, we give them antibiotics, different antibiotics, rotating antibiotics. This is called rotating antibiotics because we give them different types of antibiotics. We go from one to the other so they don't develop some kind of resistant pattern. So one week we give them trimethoprim sulfa. Then when they get infected 2 months later, we'll give them amoxicillin or something like that. They all have to do all their vaccinations. Vaccinations in these patients are very important. And then we said, in some cases, for localized disease, potential treatment is surgery. In the acute setting, acute pneumonia has to be treated with the appropriate antibiotics. And this, you have to think about these cases, because these are the patients that need antibiotics. They will treat pseudomonal infections. It's very important, because we don't tend to treat patients with pneumonia typically for pseudomonas infection, but bronchiectasis is one category that we do. So let's go back to this case. A 17-year-old woman is admitted to the hospital with right lower lobe pneumonia. She has a history of pneumonia, so that's the tip-off right there, and multiple admissions to the hospital. She has chronically daily productive cough as well as chronic diarrhea. She's thin, etc., and the lung exam shows diminished breath sounds on the right lower lobe. So right away you say chronic diarrhea. Why? Well, people with cystic fibrosis get pancreatic insufficiency. Remember, cystic fibrosis is a disease where patients develop chronic pancreatitis, right? They get bronchiectasis and chronic lung infections and so forth. And you say, wait a second, that's why maybe this patient has been in the hospital multiple times and nobody has picked it up. Now, cystic fibrosis, because we use a lot of broad-spectrum antibiotics now. A lot of patients with cystic fibrosis don't get diagnosed until later in life. We used to diagnose all these patients, early on when they're 5, 6, 7 years old. Now, about 5 to 7% of patients with cystic fibrosis get diagnosed later in life, early adulthood. This is one of them. So you have to think about that. And the right answer here is you admit the patient, of course, to the hospital always when you consider pseudomonal infections and devastating pneumonias. And this patient has to be on some form of anti-pseudomonal antibiotic. Things like ceftazidime would cover Pseudomonas. Things like the aminoglycosides. Things like the anti-pseudomonal penicillins, like piperacillin, ticarcillin, things like the fluoroquinolones. Those would be the appropriate antibiotics to treat this patient with. And that brings us to the end of the obstructive disease section.